palpation, you only palpate for tenderness, and the only 3 areas of tenderness that you need to elicit. One is your pinna tenderness. There's 4 areas. Next is your tragal tenderness. So all this signifies otitis externa. Alright, then your mastoid tenderness. Make sure you palpate the mastoid tip, and mastoid tenderness. Those who have cortical mastoidectomy done, there may be a depression, so you may not have that groove here. So you can just describe it as palpation is absent, the absence of the mastoid prominence. So that may evidence of previous surgery. You don't know any history apa semua kan? So but you describe. Alright, then you look for your sympachical tenderness lah. Okay, you see your sympachical tenderness. So this is ini suggests thrombophlebitis, especially lateral sinus thrombophlebitis, and for your sympachical tenderness. So patients who comes with AOM, and you need to elicit this mastoid and also your sympachical tenderness lah. Okay, so after your before that general inspection, otherwise you kena ear case kan, you can just say grossly the fascia is intact, macam tu saja. You don't need to go check one by one, because the question was not to check the fascia, just examine the ear. So you can just say patient is sitting comfortably, there's no obvious facial asymmetry at rest, then you terus go to your right ear. Macam tu. So I've already covered your inspection and your palpation. And after that, you will go for your otoscopic examination. Otoscopic examination is never painful, same as our rigid laser endoscopy. Okay, it should never be painful. Patient remains painful, thank you, see you 6 months. Okay, same for otoscopic examination. So untuk otoscopic examination, always be systematic in what you want to look for. Okay, you can either, you have your own style lah, right? You not necessarily follow someone punya style, you follow your own style so that you don't miss anything. So to make it nice for me, I will always go from medially then laterally, rather than daripada luar ke dalam. So I will always comment on the whatever is at the drum, look at the attic, and drum always look at the pars tensa and your pars flaccida, which is your attic. Okay, look for any retraction, look for any prominent ossicles. If you can see the ossicle is very prominent, mention that. Okay, mention what you see, any retraction pocket, any debris, keratin, any whitish discharge, all that needs to be mentioned, not just TM is intact. Macam tu lah. Okay, if TM is intact, you will see, then you describe the colour of your TM, semua tu. You describe there may be a mass behind the TM may be intact, but there may be a mass behind the TM. So there's always a list of diagnosis. Blue TM, apa, red TM, itulah. Okay, so when you want to examine, so you always, okay, again, patient is a patient, bukannya mannequin ke apa ke. So just talk to them jugalah, showmanship apa semua. Okay, cik, saya akan periksa telinga sikit ni cik. Alright, dia dah cepat ni, tak sakit apa-apa cik. Okay, so just gently pull your pinna backwards and laterally. Okay, gently introduce your otoscope. Okay, then have a look at your, okay. So some people they like to talk and say at the same time, but I would just take my time to see everything first. Alright, so you tengok TM dulu, and then baru I will go tengok luar. As I pull out, I will examine the external ear canal. Then external ear canal again is a canal. It's not just one canal. You have the anterior wall, you have the posterior wall, you have the floor of the EAC. All these may have abnormalities. Okay, patient yang pernah buat operation mastoid, the posterior wall may be absent, kan? Modified radical mastoidectomy. So you need to have a look at the mastoid wall at the back. Okay, so you need to look at a lot of normal, baru you boleh nampak what is the abnormal lah, especially for your ear canal, because some mastoid can be very contracted. You think it's a canal wall up procedure, but it's actually a canal wall down procedure. Meaning the surgeon have brought down the posterior wall, but the mastoid is so nice, cantik, jadi kecil saja. But you know it's not a normal posterior wall. Macam tu lah. Okay, so next, after you have complete your otoscopic examination, is your turning fork test. So there's a reason kenapa kita pakai jenis 1-2. Ada berapa jenis turning fork? Okay, jenis 1-2 yang kita ada kat klinik. Yang lain kita ada apa? 256 dengan? Yes, 1.28. So why do we use 512? Again, basic principles will be asked, need to know. Alright, so basically shorter 256, patient takkan dengar, patient akan rasa vibration. So that is not what you want. You want patient to not feel the vibration, but you want patient to be able to hear. Longer 1028, okay, patient tak dengar vibration, but the vibration is very short-lived. Sekejap je hilang dah. So that's why 512 is the best lah for our 24 examination. So the way to do your 24 test, again, tell the patient, okay, encik, saya akan letak benda ni dekat depan, dekat belakang. Encik bagi tu mana yang lebih kuat. Ataupun, tapi bila kita tanya mana lebih kuat, 1, 2, tapi bila kita explain, depan belakang. So patient pun tak tahu mana 1, 2. So you standardize your way lah. Okay, saya letak kat ni depan 1, belakang 2, encik bagi tu mana yang lebih kuat. So the right way is, you knock, you hear first, make sure, don't no. If examiner can hear you, that's wrong. Terlampau kuat. Okay, so you just sikit, then you dengar, always support the patient's head. Okay, 1, ini mastoid tip, 2. Mana yang kuat?
Depan.
And tuning fork is always bilateral lah. Even though the test is ask you to check just the right ear, you have to do the opposite ear. So some examiner cakap tak cantik kalau you are crossing the patient apa semua. Okay, so ini semua comes with practice apa semua lah.
So should we do?
I would just go to the opposite side.
Oh, you go. Okay.
Rather than doing this, doesn't look really nice. So I would just go to the opposite because patient can be moved. Oh, I will just turn the patient a bit. Macam tu. So ni semua it comes with practice lah. Cuma 7 minit kan nak kena habiskan semua benda tu. Okay, then is your Webers. Webers, you need to okay, again check dulu. Then you letak center. Again, support the patient's head. Then there needs to be a counter pressure. Baru patient boleh dengar betul-betul. Kalau you tak letak, patient memang takkan rasa. Okay, so you need to support the patient's head and press. So the first area is your forehead. And then some boleh, kalau tak dengar, you can try your vertex. And then your nasal bridge. Last would be the chin. Satu lagi orang cakap gigi, tapi saya tak pernah buat lah gigi apa semua. Okay, then you ask the patient dengar mana, tengah ke, kanan ke, kiri. Alright, interpretation of tuning fork test. Ni nak call tak? Okay, Rene is negative over the right side. I mean, patient is complaining of reduced hearing over the right ear. Your Rene is negative over the right side, and Weber is localized to your affected ear.
Localized to affected ear.
Okay, so that was just the right conductive hearing loss. So untuk 24, there's no way to know mixed hearing loss. You only have conductive or sensory loss. Okay, so there's always your Rene is negative. We may usually suggest conductive hearing loss, and if let's say the Weber goes to the contralateral side, that supports your finding lah. Okay, but which one is more sensitive, Rene or Weber? Weber. Okay, Weber can detect conductive loss as little as 5 decibels. So there may be certain cases you do Rene is positive, patient ada OME, and you do Rene is positive, but Weber goes to the right side. So in this scenario, you just say Rene is positive bilaterally, but Weber is lateralizing to the right side. And before that, maybe your otoscopic, you dah cakap dah TM is dull apa semua. So this is suggestive of right conductive hearing loss of at least less than 15 decibels. You just say less than 15 decibels, because Rene will only be negative if your conductive loss is 15 decibels or more. So if it's less than 15 decibels, Rene will be positive, but patient still has conductive hearing loss. Okay, so again I recap, kalau katakan Rene is positive, but Weber is lateralizing to the affected ear, his conductive hearing loss less than 15 decibels. So that is how complete answer lah. Dari compare apa semua kan, kalau short case, you get this kind of findings, then it's ni lah. Okay, so kalau Rene positive, Weber goes to the opposite ear, that will mean the left side is the better ear lah. If both side is positive. Kan faham kan? Kalau both sides positive, but wherever a patient complain of reduced hearing over right side, the name is positive bilaterally. Then whoever goes to the opposite side, which is the right ear, so you will expect this will be a sensory hearing loss. Okay. There's a bit more, one more thing, but this one I don't want to confuse you guys about false renays. What is false renay? Okay, so that one is another thing lah, kemudian lah. Okay. So after you complete your tuning fork test, you already know the type of hearing loss roughly. Then you need to examine the threshold. So I think this one is very, I think sebab banyak nak kursi yang sorry salah. So free field voice test, it is not a